This is Randy Schell recording a flipped classroom pre-session podcast on basic cardiovascular physiology, cardiac cycle, and ventricular function. It's November 2015 and follows the ABA basic exam content outline listed here. The topics that we will cover include cardiac innervation, or control of the heart rate, sympathetic and parasympathetic nervous system, electrophysiology and ion movement at the pacemaker and myocardial cells, coronary blood flow and myocardial oxygen utilization, supply and demand, ventricular function including Frank-Starling law, determinants of cardiac output and regulation, and systolic versus diastolic function, and the major cardiovascular reflexes. We will begin with control of heart rate. The pacemaker activity at the SA node is controlled by the sympathetic and parasympathetic nervous systems. The sympathetic nervous system via the cardioaccelerator nerves from thoracic 1 through thoracic 4 innervate the atria and the ventricles. The parasympathetic nervous system via the vagus nerve innervates the atria and the SA node mainly. The predominant resting tone is via the vagus. So it's like we constantly have a brake on the heart and keeps the heart rate at 60 to 80 beats per minute. An example of this is shown in the far right, where you have the T1 through T4 innervation via the sympathetic efferents to the heart and to the nodes, releasing norepinephrine, as opposed to the vagus nerve, which comes from the medullary cardiovascular center and innervates the atria and the SA node mainly, causing potentially slowing of the heart rate. And then we also have adrenal circulating catecholamines, which can stimulate the contractility, frequency, conduction velocity, and also the irritability of the heart. Circulating catecholamines via beta-1 receptors stimulate increases in heart rate. Norepinephrine and epinephrine will do this. In a denervated heart, i.e. a heart transplant where the heart is removed, the vagus nerve is cut, and the sympathetics are also cut, T1 through T4, the cardioaccelerators, this heart is then called denervated, and it will undergo upregulation of the beta receptors and still be responsive to beta stimulation. However, vagal stimulation, i.e. or via neostigmine administration or atropine vagolytic administration, should have little effect on that heart. The quadriplegic patient who has a high spinal cord lesion can lose the thoracic input but still have the vagus intact and be at risk for bradycardic episodes. Some of our medications and things we do clinically will affect the heart rate. Those things that decrease the heart rate, neostigmine raises acetylcholine levels by blocking acetylcholinesterase, the enzyme that breaks it down. Beta blockers slow the heart rate. Being cold slows the heart rate. And increased carotid baroreceptor tone via increased blood pressure, which causes stretch of the carotid receptor and will increase vagal tone to the heart, decreasing heart rate. Things that increase heart rate are listed here: anticholinergics like glycopyrrolate and atropine, beta agonists. An example would be ephedrine, which has indirect by releasing catecholamine effect, and direct effect, it acting specifically on the beta receptor itself, can increase heart rate. Increased temperature increases the temperature at the SA node and increases spontaneous firing of the SA node. And decreased carotid receptor tone, such as when the blood pressure decreases, there's a reflex increase in heart rate. Electrophysiology. The SA node and the ventricular or Purkinje fibers are shown here. Let's look at the SA node or pacemaker node first, action potentials. The SA node undergoes spontaneous diastolic depolarization during phase 4, shown here, and this is where you have a leak in sodium that comes in, a slow leak in sodium, and possibly calcium getting spontaneous depolarizations, and the SA node becomes our pacemaker for the heart in most circumstances. As opposed to the ventricular action potential shown on the far right, you can see that in blue, sodium comes in and causes the action potential, and we want the ventricular muscle to stay contracted for a length of time. Therefore, calcium comes in and maintains that action potential at the same time that potassium is going out. So it's calcium that maintains this action potential in phase 2 of the ventricular action potential. Let's look at a figure now representing the pressure flow, electrocardiographic changes, sounds, and valve action all in one. This is called a Wigger's diagram. So let's look at the EKG first on the bottom, and you can see that there is a P wave followed by PR interval, followed by a QRS complex, followed by QT interval, followed by the T wave, with systole being from the QRS complex to the end of the T wave, with diastole being from the T wave to the beginning of the QRS complex. So the definition of systole and diastole are shown here. In red is shown ventricular volume. It is filling during diastole, and during systole with contraction, obviously the ventricular volume goes down. And the difference between end diastolic volume here and end systolic volume here is stroke volume, EDV minus ESV. In the curve in blue, we can follow this curve and see that as the aortic valve closes and the ventricle contracts, it has to generate a pressure high enough to open the aortic valve. There is ejection going on, followed by aortic valve closure, and then followed by LV relaxation, isovolumetric relaxation. And when the pressure drops low enough, the aortic valve opens again, and we undergo a similar cycle. Let's look now at coronary blood flow. There's a diastolic flow predominance of coronary blood flow to the left ventricle. The right ventricle gets coronary blood flow during systole and diastole, but mainly systole. Let's look at the graph on the right. On the top right shows aortic pressure, the dicrotic notch, followed by diastolic runoff. The second graphic figure here shows left coronary blood flow. And during systole, you can see that there is little coronary blood flow, as opposed to diastole after the dicrotic notch. When the aortic valve closes, blood is flowing down the coronary artery during diastole. So diastole is very important to left ventricular coronary blood flow. And there's interruption of coronary blood flow to the left ventricle during systole because of mechanical compression of the vessels by myocardial contraction, that is epicardial to endocardial movement of blood essentially ceases because of myocardial contraction. The RV gets blood during both systole and diastole. Maximal oxygen extraction is occurring from the blood that is supplied to the heart. In fact, the coronary venous oxygen saturation is only 30%, which means that if you need more blood to the heart, we cannot, that is, if we need more oxygen to the heart, we cannot increase extraction from the blood that is already supplied to it, because maximal extraction is already occurring, but we have to increase flow to increase oxygen supply. Coronary blood flow is mathematically represented as diastolic blood pressure minus the pressure inside the heart at end diastole. Remember, the left ventricle gets its blood during diastole, so diastolic blood pressure is important, and the pressure inside the heart, how full it is and how high a pressure it is, The higher that pressure inside the heart, the harder it is for blood to go from the epicardium into the endocardium. And remember that the subendocardial area is the site of the heart that is at the highest risk for ischemia. So to increase coronary blood flow, we can give more time for blood flow to occur during diastole, and that is one of the reasons beta blockers are so effective. They decrease heart rate and provide more time on diastole for blood flow. And we can increase diastolic blood pressure, and we can decrease LVEDV. Therefore, if we give a lot of fluid to a patient and actually raise LVEDP, we can adversely affect coronary blood flow. Nitroglycerin, one of its major reasons why it has a beneficial effect for patients with myocardial ischemia is that it is a venodilator and decreases LVEDV, and therefore decreasing LVEDP. It is also a coronary vasodilator. Adenosine is a local vasodilator that helps at least partially autoregulate coronary blood flow. So some factors affecting oxygen supply demand are shown here. Supply, heart rate is important because time in diastole when coronary perfusion occurs needs to be increased if you want to increase supply. Raising coronary perfusion pressure by raising aortic diastolic pressure or decreasing LVEDP. We can either increase hemoglobin oxygen content by transfusing a patient, for example, and raising the PaO2 also. And coronary vasodilators can increase supply. Things that affect demand are heart rate, wall tension, which is affected by preload, the ventricular radius of the heart, how it's stretched, and afterload, as well as contractility. They are graphically shown at the right, so increasing oxygen demand is things like increased heart rate, a full heart, a heart that's contracting strongly and that is beating against an afterload. And things that decrease oxygen supply are reduced coronary blood flow, high heart rates, a high LVEDV, diastolic volume, coronary vasoconstriction, reduced oxygen content, reduced hematocrit, and reduced oxygen saturation. So if we compare heart rate to blood pressure, which is worse, increased heart rate is, I put in quotation marks, worse than increased blood pressure, because when you increase heart rate, you shorten the time in diastole for coronary blood flow. Moreover, increased heart rate makes the heart work more and use more oxygen, so the combination of increased myocardial oxygen consumption with reduced supply because of the shortened diastolic time puts you at greater risk for myocardial ischemia than does increases in systemic blood pressure. Because increases in systemic blood pressure may increase demand some, but it also enhances pressure-dependent coronary blood flow. Cardiac output, what are some of the determinants and regulatory factors? Remember that cardiac output is stroke volume times heart rate, and that stroke volume is the difference between how full the heart is at end diastole minus how empty the heart is at end systole. For example, 100 cc's in end diastole minus 40 cc's in end systole would be a stroke volume of 60 milliliters and an ejection fraction of 0.6. Things that affect stroke volume: preload, afterload, and contractility. Increased preload increases stroke volume, increased afterload can decrease stroke volume, and increased contractility can increase stroke volume. And some graphic representations of control are shown at the right, and let's briefly go through those. One, cardiac output is directly affected by heart rate and stroke volume. Heart rate, positive chronotropic agents, things that speed the heart up. Negative chronotropic agents, agents that decrease the heart rate. Stroke volume is affected by several things: preload, afterload, and contractility. And contractility can be affected by inotropic agents, be it negatively, like a beta blocker, or positively, like dobutamine, for example. Venous return is important because that determines preload. And some of the things that we do in the operating room, like the fluids that we give and intrathoracic pressure that we may provide with positive pressure ventilation, may affect cardiac output, and it's easy to see how when you look at this graphic. What is the Frank-Starling law, and what is the law of Laplace? It's shown here. The Frank-Starling law refers to how hard the heart contracts, the strength of contraction, in relationship to how filled it is. And so basically you fill a heart, it contracts more. Preload high, it contracts more up to a certain point, and the graphic on the top right shows that as you fill the heart more and more, it contracts more and more, and the stroke volume goes up until some point where it goes over the curve if you fill the heart too much, and then the stroke volume can actually go down. Increasing contractile state means this curve moves up and to the left, and decreasing contractile state down to the right. Law of Laplace says that the wall tension of the heart is equal to P times R over 2T, where P is the interventricular pressure, where R is the inner radius of the heart, and T is the wall thickness. So you can see that the higher the pressure in the heart, the higher the wall tension. That makes sense. The more radius the heart is, the more stretched out it is, the higher the wall tension. But notice that on the denominator is wall thickness, and as the wall thickens, the wall tension actually goes down. So it's like as you grow muscle, the wall tension will go down. You can do more work without generating so much wall tension. And that is one of the compensatory pathologic mechanisms for in LV hypertrophy, chronic long-standing hypertension, for example, or thickening of the LV occurs and it decreases wall tension. But when the heart dilates or fills to high pressures, the wall tension will go up, LV must work harder, and oxygen demand increases will occur. What's the difference between systolic and diastolic dysfunction? Well, simplistically, systolic dysfunction would be that patient with a low ejection fraction, less than 40%. Not accurate when there's mitral regurgitation of any significance present because the ejection fraction can be quite high, but where is the fluid going? It can be going backwards through the mitral valve and less going out through the aortic valve. Ejection fraction may decrease when afterload is increased, i.e. giving large doses of phenylephrine. Diastolic function we usually think of as relaxation of the heart or lusitropy, often assessed by flow velocities across the mitral valve, the classic E and A waves, passive filling followed by atrial kick, seen with echocardiography. And patients that have impaired relaxation are those that often have long-standing hypertension, the aged heart, ischemic heart, and cardiomyopathy heart. So on the bottom is a picture of a patient with cardiomyopathy, and you can see this thinned out heart, infarcted heart. This patient is going to have classic systolic dysfunction, very low ejection fraction, but may also have some impaired relaxation, but classic systolic function. While the patient with long-standing hypertension with a big, thick left ventricle may have a normal ejection fraction, but have impaired relaxation and diastolic dysfunction. So up at the top right, if you look at this pressure volume curve of volume on the x-axis and pressure on the y-axis at end diastole, represented here and here, that end diastolic pressure is a reflection of diastolic function. For example, if there's a high LVEDP and a small heart, that's classic diastolic dysfunction. We'll finish up with two slides on major cardiovascular reflexes. The first is just the classic arterial baroreceptor that's present in the carotid sinus and the aortic arch. In the case of stretch associated with an increased blood pressure, there is afferent signals that go from the glossopharyngeal ninth cranial nerve to the brainstem medulla with it goes to the brainstem medulla and then back to the heart via the vagus nerve and slows the heart rate. So as blood pressure goes up, heart rate slows. Decreases in heart rate and blood pressure occur when the stretch receptors are activated. An example would be carotid massage. When you massage the carotid and stretch those receptors, heart rate will go down and vasodilation occurs. There's two other major cardiovascular reflexes to be touched on in this podcast. The Bainbridge reflex. Stretch receptors are present at the junction of the SVC, right atrium, and pulmonary veins, and left atrium that respond to changes in volume. So basically the graphic on the far right shows that if atrial pressure goes up or stretch of the atrium, large amount of volume, for example, is present in the atrium, the heart says, I got to get rid of more volume, and the heart rate goes up. And this atrial receptor or Bainbridge reflex is a response in heart rate to volume changes in the atria, is the classic Bainbridge reflex. As opposed to the Bezold-Jaris reflex, which may be observed with acute MI and chemosensitive receptors present in the ventricular walls, results in vagal stimulation, inhibition of sympathetic outflow with bradycardia, hypotension, and vasodilation occurring. This ends the podcast that is to be before the interactive classroom. Its goal is to provide the foundational knowledge for us to have an active discussion of cardiovascular physiology in the classroom time. Have a good day.